Good afternoon, and welcome to the Musella Foundation's May Brain Tumor Awareness Month webinar series. Today, our special guest speakers are Dr. Mark Hendrick and Dr. Norman LaFrance. Dr. Mark Hendrick is the president and CEO of Plus Therapeutics. He's held a number of executive leadership roles, including president, CEO, and director at Cytori Therapeutics, and president and CEO of StemSource Inc. Dr. Hendrick is a trained general, vascular, and plastic surgeon and former associate professor of surgery and pediatrics at UCLA. And Dr. LaFrance is going to help with Q&A at the end, but he is the Chief Medical Officer and Senior Vice President at Plus Therapeutics. Dr. Hendrick, go ahead.
Okay, great. Well, thanks, you guys. It's good to join you again, and really appreciate the opportunity to provide everyone with an update. I think it's been Dr. Musella, maybe 3 years since we last presented, so really appreciate it. Appreciate the opportunity. Let me. You see the slides, okay?
Yes. Yep.
Okay. All right, great. So let me tell you a little bit about Plus Therapeutics. So Plus is a company that develops targeted radiotherapeutics for patients that have brain cancers and other central nervous system cancers. And I'll talk about how we're approaching those in a moment, but just to give you an overview of where the company is active clinically at this point. None of our products are on the market yet, and I want to focus on glioblastoma or malignant gliomas today, but we have other things in the pipeline as well, and I think it's worth mentioning those. So we have two drugs. One is called rhenium obisbemeda, and I'll show you what that is in a moment. But that is in essentially 2 clinical trials for leptomeningeal cancer, which is a increasingly common complication of a variety of solid tumors, including breast cancer, lung cancer, and melanoma. And we're also in a phase 1 dose escalation trial and a phase 2 trial for recurrent glioblastoma for small to medium-sized tumors. Very soon, we'll have a pediatric brain cancer trial up and running at Lurie Children's Hospital in Chicago for pediatric high-grade glioma and ependymoma. We also have another drug that I'll mention just briefly at the end because it's not in the clinic yet, but has potential utility in glioblastoma. And it's a radioembolic drug, and the drug is delivered through the vascular system to radioablate really any solid organ tumor, but has a lot of potential, in our view, for glioblastoma. So I know the followers of the Musella Foundation are very savvy as it relates to CNS cancers, and in particularly with glioblastoma. But I want to highlight some important challenges with respect to treating glioblastoma in particular, and then address how our technology overcomes essentially all of these key challenges. And they're listed here on the current slide, but I know your audience is well aware of the blood-brain barrier. And most drugs, in fact, only about 2% of drugs are out there will actually cross the blood-brain barrier, meaning the vast majority of them do not, which makes it very difficult to get an injectable drug into the area of interest around where the glioblastoma is. And that's one reason it's so difficult to address these tumors with standard chemotherapeutic or injectable therapeutics. We also know that some glioblastomas are chemo-resistant based on their MGMT status, but there are also some that develop chemoresistance over time, which is a common feature in many different kinds of cancer. Those are two challenges that affect almost any type of chemotherapy that one can envision to develop for GBM. But there are other therapies that are out there that are commonly employed for glioblastoma, such as radiotherapy and surgery. But those have important limitations as well. For example, with radiotherapy, and what's commonly used is something called external beam radiation therapy. It's limited by the amount of radiation that one can deliver to the tumor. And I'm going to show you how we resolve that in a moment. There's another very big problem that's based on the local invasiveness of GBM. So inherent in the biology of glioblastoma is this sort of infiltrative margin. And oftentimes it's not really visible or able to be appreciated on a typical MRI evaluation. But we know it's there, and it really is responsible for the majority of recurrences that occur. Even when one thinks that the entire tumor has been removed surgically, you still leave this infiltrative margin that's responsible for those locally invasive tumor cells that drive future recurrences. And that directly relates to the inadequacy of surgical therapy. It's very rare to completely take out the tumor. And certainly it's almost impossible to obtain clean surgical margins like we can for many other kinds of cancer, like skin cancer or liver cancer. So that combination of local invasiveness and the inadequacy of surgical therapy makes surgery not an ideal solution, although it's commonly used. And then finally, just the complex anatomy of the brain with the gyrus and the sulci and the fissures, and the fact that you have very important neural tracts in and around, often associated with the tumors, makes the adequacy of any of these therapies even more difficult. So the reason I bring this up is these are sort of commonly known unique challenges with CNS tumors, particularly GBM. And I want to show you how our therapy that's in development addresses all of these. But before I do that, let me tell you what the drug is. And I mentioned before, we have two drugs. I'm going to talk about principally here one of the drugs. It's called rhenium obisbemeda. And it's a drug that has three different parts to it. It has a radioisotope called rhenium-186 that's made in a nuclear reactor. And then it's chelated or grappled with a technology that allows us to import it into what is a very large liposome. As drugs go, it's very large. It's 100 nanometers. And it's a lipid envelope that allows the drug to stay essentially where you put it. And so we deliver this drug with something called convection enhanced delivery, which is becoming increasingly more common in the brain cancer drug development space, because it's a very unique way of bypassing the blood-brain barrier. And when you take rhenium, which has the ideal physics for treating brain cancers and neoplasms, you load it into a liposome and then deliver it by convection enhanced delivery. The drug stays essentially where you put it until all of its radiation is delivered specifically to the tumor. And it can be there for several weeks. So and I'll allude to this in a moment, but it's a single treatment that allows you to deliver extremely high doses of radiation to the tumor and only the tumor bed and the infiltrative margin, but not treating the rest of the brain or the rest of the body. So there are no systemic toxicities with the drug. And in fact, we've seen essentially no systemic toxicities with any of the patients we treated, both for GBM or other CNS neoplasms. So the key is the formulation, and it makes the drug and the isotope behave fundamentally different than it would otherwise behave when it's placed in the brain via convection enhanced delivery. So with this particular drug, we have two ways of delivering it. And on the left is, I mentioned before, convection enhanced delivery. If you're not aware of convection enhanced delivery, it's something that was developed in the NIH. It's been around for over a couple of decades. As I mentioned, it allows you to go past the blood-brain barrier. And if you're familiar with fracking in the oil and gas industry, where you push a fluid through a substance with a pressure head behind it, it pushes the drug through the area of interest. And then when you turn the pressure off, the drug stops in its tracks. And if you do that in a very well-planned and well-controlled environment, as we do, you essentially put the drug exactly where you want it. You turn off the pressure, it stops, and it treats just the brain tumor and just the infiltrative margin. And we're putting up to now 5 catheters per patient to ensure that we cover all the tumor and the infiltrative margin. We also, I'll just say this sort of in passing, but we can also deliver the drug via an intraventricular catheter. So for patients that have leptomeningeal cancer, for breast cancer, lung, as I mentioned before, they oftentimes get a small port that goes under the skin, and then it's connected to a little pigtail catheter that goes into the ventricular fluid system around the brain that allows us to deliver the same drug with essentially the same result, but in this case, treating the fluid space of the brain and not the brain parenchyma itself. So you've got convection enhanced delivery. You've got this unique formulation of a nanoliposomal drug in a very unique radioisotope called 186. And so it's sort of what we're put together for patients with GBM. It's really a completely different system and way to deliver radiation therapy. So the gold standard, as I alluded to before, for delivering radiation to brain cancers is external beam radiation therapy. It's been the standard of care for decades. And it just so happens that glioblastoma cells are very radiosensitive. The problem with radiation is sort of multifold. One is it requires fractionation. To get an acceptable safety margin, you have to divide up the radiation dose over a number of weeks. Typically, it's 4 to 6 weeks, and patients have to go into the hospital 5 days a week for maybe 6 weeks to receive very small amounts of radiation that add up over time to a therapeutic dose. But the fundamental reason behind that is because if you give a appropriately unfractionated dose at once, it can be very toxic and harmful to the patient. And that's why fractionation has become a standard way of delivering external radiation. But we have a very good idea of what radiation can and can't do by now. When given in this way. What we are now doing for patients with brain cancer represents a completely new paradigm for delivering radiation to the central nervous system and to glioblastoma. We can deliver the radiation directly to the tumor site and the infiltrative margin. We can eliminate the challenges that I mentioned before. We can actually see the drug in real time, and I'll show you a patient where you can actually see the radiation with a special kind of monitor called a SPECT scanner or a SPECT CT scanner. So we can see not only where the drug is at any point in time, but we can also tell the patient and tell the doctor exactly how much of the drug or the radiation was given to the tumor, which is an incredibly powerful and unique system to monitor patients as they go through therapy. We can quantify the absorbed doses. And as I mentioned, we do it in a single dose. It's a single therapy, not a fractionated therapy delivered over 4 to 6 weeks. A completely different paradigm in terms of treating patients with glioblastoma with radiation. There are two kinds of workflow I think it's important that patients understand. One is really from the standpoint of the hospital and from us interfacing with the hospital as the developer of the drug. When the patients are diagnosed, in this case with a recurrent glioblastoma, we simply get a call from the doctor saying they're going to schedule the patient and have a biopsy and have catheters placed. And then we manufacture the drug in a centralized manufacturing facility under the highest standards. And then it's delivered overnight the day before the surgery. So it arrives first thing in the morning, bright and early when the patient is admitted to the hospital. It goes through standard shipping and receiving, and it's made available for the patient when they need it in the hospital. Very straightforward workflow from the hospital's end and the doctor's end. Now, most importantly for the patient, the workflow is extremely streamlined. And this is the way it works for an individual patient. And now I'm talking about for patients that have recurrent glioblastoma. These patients, after they're diagnosed and receive their initial treatment, they're followed typically every 2 months with an MRI. And when there's an area of concern that the tumor might have come back, they're referred to us. We and our team, including Dr. Brenner, who couldn't be with us today, will develop a treatment plan personalized for that patient. And that's done on a specific software made by a company called BrainLab. And that technology allows us to identify the region of interest. We can see it. We can draw a marker around the area we intend to treat, both the tumor and the infiltrative margin. And then the software tells us how we can put catheters into and around that area to optimally cover that tumor with the minimum number of catheters. And then it tells us exactly where those catheters should be placed within 3 dimensions in depth. And so that whole treatment plan then gets loaded digitally into the computer in the operating room. So when the patient comes in, is admitted to the hospital, they go immediately to the operating room. The doctor takes that data and the neurosurgeon does a biopsy to confirm that there's tumor there. And then up to 5 catheters are placed using the neuronavigational technology. And then those catheters are secured into place. And then the patient goes down to nuclear medicine the day after that procedure. And the drug is infused through those up to 5 catheters. And then that takes about 2 to 4 hours, depending on how many catheters are there. And then the catheters are removed and the patient goes home. And that's it. It's not 4 to 6 weeks with daily visits to the hospital. It's a couple nights in the hospital. A patient can watch TV at night between the biopsy and the catheter placement and the infusion the next day, and then they're removed and they go home. So very straightforward for the patient, much different than with external beam radiation. Let me talk about glioblastoma for a minute and how this technology is working in the clinic. So I'm sure much of your audience is familiar with malignant gliomas or glioblastoma, but if not, let me just remind you that there are about 15,000 patients that are newly diagnosed with GBM every year. Patients don't do well with this diagnosis for the reasons I mentioned before. And in the recurrent setting, after the initial treatment, which almost generally is not curative, the patients recur. And then at that point, the median overall survival in those patients, even with standard of care, is about 8 months. And so there have only been about 5 FDA-approved therapies in the last 50 years for GBM. And generally for patients that have recurrent cancer, the NCCN, the National Comprehensive Cancer Center Network, recommends that clinical trials should be considered for these patients. So as I mentioned, there are about nearly 15,000 patients with recurrent glioblastoma. The ones that have a tumor that we treat, which is about 20 cc's or less, is about 2/3 of those patients, so about 10,000 patients. But we think that this technology ultimately can be useful in approximately 1/3 of patients that have primary glioblastoma, potentially as a replacement for external beam radiation or surgery. But as I mentioned, we think it can be useful for pediatric cancers, including high-grade glioma and ependymoma. We'll be starting a clinical trial for that, hopefully by the end of this year. But also a much larger group of patients that have brain metastases from a variety of different solid tumors potentially could be patients that could use this technology as well. So now let me sort of marry what I talked about initially, which is some of the limitations for and difficulties with treating glioblastoma, how our technology works. So as I mentioned, there's an infiltrative margin around glioblastoma. You can see it in the left panel. There's the tumor that you can see on a typical MRI, but we know that there are tumor cells that extend beyond that, and those are responsible for the recurrence. And about 90% of recurrences occur within about 2 centimeters of the primary tumor. And as I mentioned, surgery is typically inadequate for getting margins to cure the tumor. Systemic drugs don't get to the tumor, and external beam radiation just can't deliver the kinds of radiation doses to treat the tumor, but also to spare the normal tissue. And so the goal with our therapy is really a different sort of approach to GBM, and that is to treat both the tumor and the infiltrative margin with at least 100 gray of radiation. And I'll show you that in patients we've treated, we're now treating patients up to over 700 gray of radiation. Radiation is measured in something called gray. That's the absorbed dose. And the typical dose of radiation in patients with recurrent glioblastoma, when it can be given, is about 35 gray. And even in the primary setting, when patients are first diagnosed with glioblastoma, it's not much more than about 35 to 50 gray of radiation. So the goal is to treat the tumor you see and the tumor you don't see. That's what we're trying to do here. So here's an example of a patient that was treated with external beam radiation on the left, and a patient that was treated on the right with rhenium obisbemeda, our drug. And these are kind of standard examples. This is not our best case, the maximum dose, but this is a pretty standard middle of the road case for both EBRT and rhenium obisbemeda. So on the left, you see the lines which represent the dose fall off for radiation. So the radiation's pretty well gone when you get out to the white line, but the tumor you can kind of see that's colored in green. And the maximum dose you can get to the tumor, absorbed dose to the tumor with external beam, is about 30 gray. Here, this patient got 28.5 gray, the maximum dose, and then 5 gray of radiation out to here. And this is really inadequate to treat the tumor. But if you look at this patient, you can see the white tumor that lights up on the MRI. And you can see that the absorbed dose to the tumor itself was 250 gray and 5 gray out to the green line. So we're treating with a very high dose of radiation, not only the tumor, but the surrounding infiltrative margin with rhenium obisbemeda. So where are we in development with this novel therapy? So the trial is currently in a phase 1 dose escalation trial and a phase 2 trial for patients that have medium to small recurrent glioblastomas. And this trial is funded almost fully by the National Cancer Institute here in the United States, and we're appreciative for that support. So we've now treated. We're in the 8th cohort. So we started off at a very low amount of radiation, or 1 millicurie of radiation, and we're now treating safely using 40 times that amount of radiation, a very, very high dose of radiation. I don't think this has ever been done in the history of medicine, to deliver this high amount of radiation safely to patients. And we're also delivering it in about 16 milliliters of volume. So there are 2 parts to the dosing. There's one is the amount of radiation, but how much volume we put in too, and that volume and radiation are specifically meant to not only deliver the tumor-killing radiation, but also the volume that will cover both the tumor and the infiltrative margin. However, so even though we're currently dose escalating, when we're still in cohort 8 at this very high level of radiation, what we found is that in cohort 6, where we're treating with about half the volume and about half the radiation, that looked to us to be safe and effective in patients that had small to medium-sized tumors. So we continue to push the dose up for patients that have bigger tumors or unusual clinical situations. But we think for the majority of patients with recurrent glioblastoma, this 8.8 milliliters and 22.3 millicuries can be potentially safe and effective for patients with glioblastoma. So let me show you a little bit about the safety. So the trial safety summary is listed down in the right. And we've had essentially very few complications, even at very high doses of radiation. Things like headache, fatigue, which are common with radiation, occur, but to a small degree as adverse events in the trial. And there's been no evidence of systemic radiation toxicity or the kind of fatigue and debilitation that patients get with external beam radiation. And this data is from the first 28 patients in the 8 dosing cohorts. And I want to just kind of show this graphic on the top right. And on this, these numbers that are going from 0 up to 450 is the amount of absorbed radiation that we're getting. Remember, I said that in recurrent glioblastoma, they get on average about 35 gray, which is down here. So this is a cohort 1 up through cohorts 5 and 6. And this is roughly where we are right now in the phase 2 trial. We're giving around 350 gray, or 10 times the amount of radiation that can be delivered with external beam right now. It's a very high dose. So if you're familiar with glioblastoma clinical trials, oftentimes early on in a trial with a phase 1 or phase 2, you don't have really good survival data upon which to anchor your evaluation of whether something's working or not. This happens to be very different. We have survival data for both of our phase 1 and phase 2 trials. As this trial's actually been going on since 2015. This started as an academic trial at the University of Texas and MD Anderson in Houston. And so we have a lot of longitudinal follow-up prior to Plus's involvement with this technology. So I'm going to show you 2 sets of charts. So these are survival curves. They're called Kaplan-Meier survival plots, or they show the probability of survival over time. And the thing to know on the left is the progression-free survival for all of the patients, which is the blue curve. And on the right, there are 2 different curves. The red curve is the patients in the phase 1 that got a therapeutic dose, or over 100 gray. And then the ones in blue are the ones that got less than a therapeutic dose. So we looked at the data in 2 ways. One is therapeutic versus non-therapeutic, and one is as a whole. And the reason we do this is because in a dose escalation, you start off, as I showed you, with very low volumes and very low doses. So we know that that's likely not going to be therapeutic for most patients. And not surprising, those patients that got a very low dose don't do as well as the ones that get the higher dose. And that's what the progression-free survival shows on the right, that the patients that got less than 100 gray, their median progression-free survival was only 2 months, but it was 6 months if they got greater than 100 gray. And that carried over in looking at the patient's overall survival. And for all patients, including the ones that got a subtherapeutic dose, the median overall survival was 11 months. Remember, the typical median overall survival is 8 months in recurrent glioblastoma with standard of care. But the patients that got greater than 100 gray, their median overall survival was 17 months. So well over double the survival of patients that got standard of care. So that was our phase 1 signal. It suggested that this was not only safe, but was potentially effective in patients that have a tumor of 20 cc's or less. So based on the trial, we went into a phase 2 trial. And I'll show you the latest phase 2 data from the trial that was presented at the Society for Neuro-Oncology last November in 2023. And the data shows a similar pattern to what we saw in the prior data. But what's different here is these are all patients that were in the phase 2 group. So we're not selecting out the patients after the fact that got a high dose or a low dose. This is patients that all got the same dose, the cohort 6 dose of 8.8 milliliters and 22.3 millicuries, and then follow them out for their progression-free survival and their median overall survival. And on the left, in terms of progression-free survival, that was 11 months. The data presented in November, which is a very good median PFS for these patients. And the median overall survival was 13 months, which is about a 63% improvement over standard of care. And this is with a number of patients. I think about half these patients were still alive at the time that the data was evaluated. And so that trial continues to enroll, but the survival signal is very promising. And let me put that survival signal again early. It's not a phase 3 trial. It's a phase 2 trial. But let me show you some comparative data to put that in context. So there's something called real world data that you may have heard about if you've looked into potential glioblastoma trials for patients with GBM. And you can actually look at very similar sets of patients, for example, patients in our trial, but then have been treated with other therapies. And one approved therapy for recurrent glioblastoma is bevacizumab. And that's been approved, but largely helps with symptoms, but does not improve survival in recurrent glioblastoma. And the median overall survival from a very large meta-analysis looking at 700 patients with recurrent glioblastoma who had monotherapy bevacizumab, their median overall survival was under 8 months. That's an important comparator. When I say standard of care is about 8 months, that's one data point that we use. But in the middle, the two orange bars represent two real-world, what are called propensity match controls. So very similar population to the ones we treated in our ReSPECT clinical trials. That's the name of our glioblastoma trial, the ReSPECT GBM trial. We did two cuts to those in concert with the FDA, who asked us to do particularly one of them, the one on the right. And that represents about 800 patients. Again, the median overall survival was right about 8 months. So we think that 8 months standard of care is a very good modern number for what can be expected in a large group of patients that have recurrent glioblastoma. And that compares very favorably with the bars in the blue, both the patients that got a therapeutic dose in our phase 1, where the median overall survival was 17 months, and 13 months in patients that were in our phase 2. So still a bit early. It's mid phase 2, but very promising data at this point. So now we'll have time for questions afterwards, I hope. But just want to go into just a couple of new areas for patients that might be listening in or looking for new options for pediatric brain cancer. So we just received funding from the United States Department of Defense to move this clinical trial forward. It'll start off at Lurie Children's Hospital in Chicago, and that's a trial to treat patients with ependymoma or with high-grade glioma. High-grade glioma is very diffuse. It can be a difficult tumor to treat because of its diffuse nature, similar to glioblastoma. And we think our approach to glioblastoma will translate over into high-grade glioma. In addition, ependymoma, although in a sense less aggressive, it's a chronic disease and very difficult to eradicate. Patients can undergo many different surgeries in an attempt to reduce the disease, but it's very radiosensitive, like high-grade glioma is. And we think both indications are potentially very amenable to the use of rhenium obisbemeda and this kind of next generation of approach to delivering radiation to the central nervous system. So now I'm going to turn to a second drug that's not in the clinic yet, but we think holds a tremendous amount of promise for a variety of solid tumors, including glioblastoma. So this drug is in ways similar to the one I showed you before. It includes radiation that's encapsulated in a liposome, but then those liposomes are encapsulated in a much bigger structure that's about 100 to 1,000 times bigger. It's called the microsphere. And there are two products on the market that have been around for about 25 years that are called radioembolic drugs. They're drugs about this size, but they're made out of glass or non-resorbable material. This is a next generation called a radioembolic or selective internal radiotherapy, where using angiographic techniques, and what those are ability to make a small needle stick in an artery in the groin or in the arm, and then a catheter under radiographic visualization can be put into the tumor just upstream in the blood vessel where the tumor is. And then this drug, and we call the drug RNL-BAM. It's just a short acronym for the long word that it is. And then it's delivered into the blood system and then deployed there. And then it delivers all the radiation into the tumor. And then it's bioresorbed by the body within a few weeks. And then it's gone. So you get that effect of no circulating toxicity, but all the radiation is delivered to the tumor. And we think this could be used alone or perhaps in combination with our rhenium obisbemeda drug for glioblastoma. And so I think just I've got a few extra minutes here, and I'll just say a little bit about leptomeningeal cancer. Metastatic brain cancer, as well as breast cancer, lung, melanoma, and other cancers are at risk for developing cancer of the cerebrospinal fluid around the brain and spinal cord. That's called leptomeningeal cancer. It's growing very fast because we're doing a better job as physicians and caregivers to take care of the primary tumor like breast cancer, melanoma, but those cells are escaping and popping up into the central nervous system. And then once there, many of the same principles around glioblastoma apply. In other words, there's a blood-brain barrier, very difficult anatomy. It's very difficult to get drugs there. And the rhenium obisbemeda drug that we use for GBM can be used as well. And this is the safety data from our phase 1 trial. The blue bars here are a measure of systemic absorption. There's very limited absorption of the drug to the spleen, the blood system, the liver, bone marrow, and so forth, but very high doses of drug to the ventricles where the blood, where the CSF circulates, and the subarachnoid space in the spinal fluid. So very safe safety profile, but very high doses of radiation to those areas. And then what we've shown, and I'll end with this, is that in the first group of patients that we treated also reported last November at the Society for Neuro-Oncology that we were reducing the tumor cells in the cerebrospinal fluid with a single dose, and arguably a lowish dose of the drug by, on average, 50% reduction in tumor cells with a single dose early on in the trial at the lower cohorts. And we're getting up to 90% reductions in the tumor cell count. And the median overall survival for patients with LM is very poor. It's only about 4 to 6 weeks without treatment, and maybe 2 to 4 months with treatment. And we showed a median overall survival of 10 months in the first 10 patients treated with a mono dose of the therapy, and 5 of those were alive at the time that we presented the data. So I think with that, I will open it up, Vanessa and Dr. Musella, for questions.
Yeah, thank you so much for that presentation. We're excited to see your data last year at SNO and excited to see the progress moving forward. We do have a patient on the line that's interested in the potentially the upcoming trial for pediatric high-grade glioma and ependymoma. Do you know when that trial is anticipated to open?
You know, I'll, Dr. LaFrance is very involved with that and talking with the site. So Dr. LaFrance, would you mind providing some guidance on that?
Yes. Hi. And Vanessa, can you hear me okay? I want to make sure. Okay, great. Thanks for the question. We're very excited about the pediatric trial. And as you might understand, FDA has a great deal to say about the exact starting of the trial. We will be submitting and concluding the formal IND submission in the next weeks, and hopefully, in mid-July probably. FDA and Plus have talked about this considerably, and depending on the number of iterations that might be necessary and that may not be necessary, an optimistic viewpoint would be ready to enroll patients by the end of the year of this year.
Okay.
We will initially focus on the Lurie Children's Hospital site as the primary site, but we will be in parallel investigating, I'll call it a West Coast and an East Coast site. They're well-known sites, but since things have not been finalized with them, I want to provide the courtesy of not committing to their names at this point. But Lurie Children's in Chicago has been an excellent collaborator, is very keen on and have been working with us very carefully. So we're making every effort to open that trial by the end of the year.
Great. And for a patient that just already has an Ommaya reservoir placed for other reasons, is it possible to deliver this therapy that way, or does it have to be, specific catheter placement with the Brain Lab software?
Yeah, so for leptomeningeal cancer, there are three ways to get it there. One is an Ommaya reservoir. Some patients may have a shunt in, or via lumbar puncture. There are three ways to access the CSF. For patients that have GBM, where there may be cells, cancer cells in the fluid, but you're really focused on the tumor itself. Really, convection is the only way to get at that, and that requires a specific MRI, the case planning protocol that I mentioned before, and then in combination with their confirmatory biopsy, a placement of up to 5 catheters to deliver the drug to the tumor and the infiltrative margin of the tumor.
Mm-hmm. And with all catheter procedures, you have risk of infection. Are you seeing that in the phase 1 and the phase 2 trial?
We have not had any infections with the catheters. I could tell you that generally speaking, with catheter infections, they're a function of how long the catheter has been in, because it provides a tract where bacteria can get into the body. So since these are really in, maybe 24 to 36 hours, patients are all in the hospital. They were placed in a sterile condition, then they're covered with a sterile bandage, and then they're really only accessed once to deliver the therapy and then removed immediately. We've had no infections whatsoever. And I think that could always happen, but would be rare.
Great. And how about radiation necrosis? Are you seeing that in the trials?
We're really not. So, and I want to be specific. So there's, generally when people bring that up, they're referring to the normal brain and tissue. And that's comes about, and I'll let Dr. LaFrance comment as well. He's much more experienced in radiotherapeutics than in his clinical past. But when you think about radiation necrosis, you're thinking about external beam radiation, and you're thinking about if you will, sort of that cone of radiation that goes, some cases goes through the tumor and out the other side into the normal brain. So we really haven't seen any evidence of that. Where we have seen radionecrosis is in the tumor. And so, which is what you want. That's the goal. You want radiation necrosis of the tumor, but not the normal brain. And then we have it's common to see that the cancer dying. And then oftentimes patients where the cancer is dying, which is what you want to see, there can be swelling. And so we treat almost every patient with steroids for a period of time to control that swelling. And generally that takes care of that tumor necrosis, but it's not really needed for the normal brain and tissue, which is the goal here. Okay. And Doctor, do you want to weigh in on that as well?
Mark, you did a great job on describing it. And I think that the comparison to external beam is valid, because that's where the radiation necrosis issues have been described. I think Mark mentioned, and I think most of the audience must be aware of the premise of pseudo progression, things like that. So Mark's explanation in terms of not seeing it is correct. We've not seen it. We've done a lot of patients. We're well into the phase 2 for what we think will be after we complete this NIH trial that we're presently conducting. We'll likely use nearly an identical trial to be, agreed to with FDA. But since we've been so successful, it'll be, if not identical, very similar in terms of the administered dose. But importantly, the one premise I would provide that, from my perspective, external beam, as folks know, is although fractionated, that energy delivery is over seconds to minutes, and it's recurrent, a number of days over a number of weeks, and days per week, and a number of weeks. With the rhenium-186 with a 90-hour half-life, that energy delivery occurs over many hours to days. And so, the energy delivery is very effective. We're seeing evidence of that in the data that Dr. Hendrick delivered and already showed you, for example, with the Kaplan-Meier curves. But I think one of the things that help us is the energy delivery is more measured over a longer period of time. But the bottom line is we're in the middle of a developmental study. We're watching that carefully. We've not seen it, and the necrosis we see is where you'd want it in terms of the tumor treatment. Thank you.
Okay. In the phase 1, you did not hit a max tolerated dose. So how did you select the phase 2 dose? And it sounds like you think you've got the right one. But at some point in the future, could you also do repeated doses, like at second recurrence or third recurrence?
Yeah, thanks for asking that question. It's important. So when we looked at the data, and this is in some of our other presentations, but there was a very highly statistical correlation with the amount of volume and radiation that was delivered to the tumor, which correlated with the patient's survival. Kind of makes sense that the more radiation you get to the tumor, and the better you cover the tumor and the infiltrated margin, the better the patient does. But we can show that very clearly, and that if people that are fans of statistics, the p-value was 0.002 and 0.003 in that. So highly statistically significant, even a small number of patients. So almost to the point where, Vanessa, we can treat a patient, look in the first 5 days, we know how much radiation was delivered to the tumor, because that's where we calculate it. We have a pretty good idea how the patient's going to do. So what that does is it tells us, okay, this patient, things really turned out beautifully, and we can feel confident. Patients still have to be surveilled, but that they're going to do well. But some patients, oftentimes because of the anatomy, sometimes the tumor is right next to the fluid space of the ventricle, or maybe they've had surgical resection before, and some of the fluid goes there, not in the tumor where we want it to go. We can see that because we can see the drug with an imaging technology. We can know whether those patients should be retreated. They can go back even very early to be retreated. And so we now have an active protocol for retreating patients. We've yet to retreat a patient. We have for leptomeningeal cancer, not for GBM. So the way I envision this rolling out is that for these small to medium-sized tumors, and I'll address your question about that in a moment, we treat them, assess them in real time. We don't wait for it to come back. We assess their imaging in the early post-treatment phase, and then we bring them back for an additional treatment if needed. In conversations with the FDA, to your other question, they ask us to continue to dose escalate. Frankly, I think they were surprised that we're delivering so much radiation so safely. And so even though we felt like we saw a safety and an efficacy signal at our cohort 6 dose, they've encouraged us to continue to dose escalate, to look at the, what is the maximum tolerated dose that we can give this technology. And because nobody's ever done this before, it's really kind of going in a very interesting, new and exciting direction.
And specifically the audience member who's interested in the pediatric trial, will those doses, are you going to start again with dose escalation with the very low dose, or do you feel like you've established a safety that you can start at the higher doses for that trial?
Dr. LaFrance, I'll let you weigh in on that.
Yeah, we are taking benefit of the adult data for sure, but these phase 1 dose escalation studies are primarily safety studies. At the same time, we recognize the responsibility to try to provide some patient benefit, but we don't want to promise that. So we're going to balance respecting safety, patient safety, but at the same time taking best benefit from the adult study. An example of how we're doing that in the pediatric study will be dose escalating both volume administered. Dr. Hendrick had already alluded to that part of it, both volume and administered dose. So we will be cautious, and which is our requirement certainly in a phase 1 safety study. At the same time, recognizing that we do have some excellent adult data that we're taking full benefit of and leveraging a lot. So we're gonna walk that line of trying to provide the opportunity for benefit, but respecting safety.
Sure. And you provided that, graph with the bifurcated less than 100 gray over 100 gray, but is there like a dose response survival curve, visual that people can see?
Yeah, so there is, and it's sort of built into that graphic, and that that sort of 100 gray cutoff. And the reason we use that, quite frankly, is that's what we noted in the animal and preclinical studies, and it actually just translated beautifully over to patients. But to that point precisely, so we actually fractionated. There's a separate graph, and I think it might be it's one of our previous presentations, where if you can separate patients by quartile, and the patients in the lower quartile in terms of absorbed dose did the poorest. The ones in the second quartile, higher absorbed dose, did better. Third was even better than that, and fourth was the best. And what it told us is we haven't reached a max, and that's why I think this technology is just in the infant stages, in the sense that we don't know how good this can actually be. We don't know how. Maybe the ideal dose is 1,000 gray, or not 350 gray on average, and maybe it's a broader coverage of the tumor because it seems to be safe to normal neuronal tissue, but very toxic to cancerous tissue. So I think we've got a great signal now. That data that you mentioned is on our website. But yeah, it's highly statistically significant. The more radiation, the better.
Okay. And is there any reason that this couldn't one day replace the standard of care external beam radiation that all GBM patients get, that 6 weeks?
I think it has a chance of doing that, because just the magnitude of the difference in radiation. Certainly, there's been 50 years of external beam therapy and development, and so it is. It's very well developed, and the delivery techniques and the modeling are very advanced. I would say we're using what EBRT has developed over those years, but we're kind of taking it to the next level with this kind of different approach. But I see what we're doing really kind of scratching the surface of what might be achievable.
Okay. And I know you're still going to have to, complete this phase 2 and do the pivotal phase 3. Will there be any chance of expanded access, at any point in this process?
There are, and so and I appreciate that question. So We've been in a very limited number of sites. We've been focused really in Texas. We have three nationally recognized cancer centers in Texas that have been doing the brunt of the patients. We just announced we'll be expanding into three new metropolitan areas. One is in the upper Midwest. That'll be at Ohio State. Another one will be at the Lenox Hill, North Shore, Northwell system in the greater New York area, and Advent Healthcare in Florida. So we'll be expanding geographically, and then we continue to be aggressive. If we find a patient that maybe doesn't exactly meet the inclusion criteria, but we think that they might be a candidate for this, we'll look at that on a case-by-case basis. And as we get kind of more down the road, we'll consider a formal EAP.
Great, that's great to hear. And we're at the hour, but we do have a couple questions about eligibility for the current trial. Do you have a few minutes to answer those?
Sure, of course. And I'll invite Dr. LaFrance to weigh in as well.
Okay. The first is we have a lot of international patients that watch these webinars. Would a Canadian or any other international patient be able to enroll in the trial?
Dr. LaFrance?
Right now, we don't have the capability to ship the drug to Europe, and plus the site where the patient might be would have their requirements for investigational product. So at the current time, the domestic administration would be the most straightforward, and that means travel. So if a patient is well enough to travel, our strongest recommendation would be to contact, and by contacting us and the clinical ops, our clinical operations colleagues can help with those introductions to get a referral to one of our existing sites. As folks on the call, and particularly international folks, may realize, many hospitals, and particularly academic hospitals, which is where this trial currently is being conducted, have the capabilities to provide access to international patients. Requires their planning, calling, and scheduling, and all of that. And oftentimes time is of the essence. That's complicated, but for an international patient, I think that makes the most sense and the best way to potentially gain access to this therapeutic option.
Okay, and we'll post the recording of this webinar and hopefully along with some contact information to access those centers. Are there any prior treatments or drugs that would prevent you from being eligible for this trial?
At the current time, it would be Avastin. We're in the midst of modifying that. The Avastin of that class of drugs has the longest half-life in terms of interfering potentially with the treatment. But the short answer is Avastin currently is a contraindication for contraindication is not the right word. It's an exclusion criteria because of some of the earlier data we saw with people who had gotten Avastin in the near term. But currently that is a protocol requirement to be Avastin naive. And
after the treatment's administered, after a certain period of time, are there other treatments you could, leverage? Could you use Optune?
There's not a lot of data on the use of follow-up treatments. Of course, we've studied enough patients that have gotten post-treatment interventions. We encourage that in the best interest of the patients. Obviously, they have to deal with this diagnosis. But we've not seen any complications with any post-therapeutic intervention after this therapy. And I might add, we would not expect any issues. This is a very localized treatment. The mechanism of action is very clear in terms of energy transfer to the tumor, which disrupts tumor DNA and kills the tumor, and does not result in interfering with post therapeutic interventions if indicated.
Okay, okay. And you mentioned small to medium-sized tumors. What exactly is that size restriction?
Yeah, so Doctor, I'll let you go ahead.
No, go ahead, Mark. You had mentioned it already.
Yeah, yeah. So 20 milliliters or less. I think our analysis of the medical literature suggests that about 2/3 of recurrent glioblastomas are in that size range, and about 1/3 are greater than that. So we can. It's a bit fungible because it does depend on location too. But as a rule of thumb, 20 cc's is about right. And if patients are are diligent about getting their MRIs every couple of months, you'll catch recurrence. Generally, they'll be in that range or less. Oftentimes, quite a bit less.
Okay, and multifocal tumors, would they be eligible for the trial?
They're not currently eligible for
Okay.
that. So there's a chance that could change in the future, but not currently.
Okay, okay. And I think maybe last question or close to last question is, there's no standard of care at recurrence. So, at what point compared to the other therapies that are available should somebody consider this trial? In terms of if their choices are between laser interstitial thermal therapy or gamma knife or the trial, how does that, I guess, how do you counsel that decision?
So I'm biased, but I'm biased based on what I've seen with our trial and other therapies, and I think what we're doing has the best theoretic chance to treat not only the tumor but the infiltrative margin. We can push the radiation out into the infiltrative margin, where maybe it looks like normal brain on the scan, but we know there's a probability of cancer cells there, and then doesn't preclude having bevacizumab or some other therapy later. And we treat the tumor, as if you were having surgery, but also that infiltrative margin itself. So it's a bit, in that sense, it's a bit like radiation and surgery and drug therapy all rolled into one in terms of that approach to therapy. And it's a bit of a speculative answer, but I'll let Dr. LaFrance take a turn at that too.
Again, not surprisingly, a great answer by Dr. Hedrick. And my disclaimer is a similar bias. I've seen our data and so forth. And what I'd offer, the patient, their family, their doctor, they all have to discuss what's best for the patient, quite frankly. I know Mark believes that, and we counsel that. And you're absolutely right that the patient's options are a clinical trial. I think our clinical trial ranks right up there as a very good option. We have the data there. It's not only the option. What I would emphasize is our option is very well tolerated. The access is really the most, I'll call it the most risky part of it. And I don't want to make light of it. It is a neurosurgical procedure, but it's one that's quite easy. And compared to a craniotomy that these patients have been exposed to, really is quite trivial. And again, I don't want to downplay the fact that they have to go through that. But our intervention has shown some benefit, at least in this early preliminary information. It's well tolerated and does not preclude people from going on to another trial later on, in addition to being qualifying for our retreatment trial. So one of the things they'll have to consider in their infinite wisdom in discussing that among family and their physicians on what their best options are is, I would very strongly say this is one of their best options. Is it their only option? Of course not. But is it a very viable option that's well tolerated? Yes, it is. And it's a tough decision that they have to feel comfortable with and discuss with their physicians and family. So hopefully that helps.
Okay. I keep getting in questions in the chat. These are great questions. Sorry to keep you going though.
No.
How do you decide which way to push the radiation dose out into the infiltrative margin? Especially because there's some difficulty in interpreting the margins on with our current imaging limitations?
Yeah, it's a great and sophisticated question. So the couple of answers to it, not just one. So the software we use to plan has some features that allow you to model out what the extent of the radiation will look like. They're not optimal for our drug. It's really made for gadolinium, which is another drug that's used oftentimes with other types of therapies that are used with convection enhanced delivery. But that's an important set of feedback in terms of the planning that we use. The other thing that's probably more important is that you can use the T2 flare on imaging as a proxy for that, potentially PET scanning as well, to determine that from an imaging perspective. And then we have a single case planner, so that this kind of gets to the core of your point. So Dr. Brenner, who's a neurooncologist at the University of Texas, who couldn't be here with us today, but he does all the initial plans himself. So he's got, he's done, nearly 50 cases. He's done every patient. This started back in 2015 to today, so getting close to 10 years of experience doing convection enhanced planning for targeted radiotherapy. So you've got the person that's got the most experience in doing that in the world. And then we always have a conference call with the neurosurgical, or typically the neurosurgeon. And then we go through that with him or her, and we use that neurosurgical input to tweak maybe catheter placement or direction or so forth. Then Dr. Brenner goes back a second time, does the case plan, then it's agreed to by the clinical team and us, and then that's what gets downloaded. So that combination of using the existing software, additional imaging, and the expertise of Dr. Brenner, and that iterative process with the neurosurgeon, even though it's a lot of touch time, it's a lot of work, that's how we think we get the best result. And there'll be opportunities over time to streamline that into maybe a single software that does that, but that's something that we're working on downstream.
Yeah, thank you for explaining that. Good way to visualize it. There's lots of questions on trial specifics and eligibility, but I'm going to defer those, to the contact information we'll share after.
Clinicaltrials.gov too has those right up front.
So just to close, final question. You shared data last year in November. Do you anticipate that you'll be able to share updated data later on this year? And kind of when do you see the estimated timeline for closing phase 2 and transitioning to phase 3?
So it really depends on how quickly these new sites can contribute. So we've been running the trial with 3 sites, and that the NIH funding was essentially limited to 3 sites when it was granted. And now the company is kind of taking over, now that we're the sponsor, expanding the trial. And so if those new sites come on and contribute as fast as we think they can, and we'll see, but then we could potentially be through with enrollment by the end of this year or early next year. That would be the goal. And then based on that, towards the end of the year, we'll be continuing our dialogue with the FDA. We've already had a lot of discussion about what a pivotal trial approach would look like. We have some significant agreements, but a little bit more work to do with the FDA. So that will be likely going on towards the end of the year. And then in terms of the pivotal trial starting up, that will kind of be depending on when we get data. But I suspect that we'll have a meaningful update in the end of 2024 at either one of the major neurosurgical or neuro-oncology meetings and update the data set. It won't be with the complete follow-up. That will take time, but potentially that could be with all the patients enrolled. That would be the goal. It's probably a pretty lofty goal, but that's the plan.
Great. That's wonderful. It's great to hear. we're excited for it. Thank you so much for this presentation, and for answering all of our questions.
Thanks
Great
for the
questions.
opportunity. Thank
I
you
just
very
wanted
much.
to add one more quick thing.
Oh,
In the brain tumor world, it's very, very rare to double the survival of recurrent GBM. So even though you may look at it and say it's only an extra 8 or 9 months, that's a huge milestone of doubling survival at that point. That's a trial worth looking into. Good evening.
Thank you. Thank you, Dr. Musella. Thank you, Vanessa.
thank you.
Thank you, everyone.
Okay, bye-bye.
Thanks for the participants. Bye.